Nutrition therapy in type 2 diabetes emphasizes on achieving glucose, lipid, and blood pressure goals. Modest weight loss has been associated with improved insulin resistance. Therefore, weight loss is recommended for all individuals with diabetes who are overweight or obese. There is no one proven strategy or method that can be uniformly or generalized. A nutritionally adequate meal plan with appropriate serving sizes and a reduction of saturated fat and trans fat, low carbohydrates can decrease caloric consumption. Spacing meals is another strategy that spreads nutrient intake throughout the day. A weight loss of 5 to 7% of body weight often improves blood glucose levels even if ideal body weight is not achieved. Weight loss is best attempted by a moderate decrease in calories and an increase in caloric expenditure. Regular exercise and adopting new behaviors and attitudes can help facilitate long-term lifestyle changes. Monitoring of blood glucose levels, hemoglobin A1C, lipids, and blood pressure provide feedback on how well the goals of nutrition therapy are being met. A healthy balance of nutrients is essential to maintain blood glucose levels and overall health. Energy from food intake can be balanced with the patient's energy output. Patients plan their individualized meal plan with their lifestyle and health goals in mind, and we need to make sure that we utilize current evidence-based guidelines from the American Diabetes Association. Carbohydrates include sugars, starches, and fiber. Carbohydrates provide important sources of energy, fiber, vitamins, and minerals, and are therefore important to all people, including those with diabetes. Foods containing carbs from whole grains, fruits, vegetables, and low-fat dairy are part of a healthy meal plan. The recommended dietary allowance for carbohydrates is a minimum of 130 grams per day. Typical recommendations are between 45 to 60 grams of carbs per meal and 15 to 20 grams of carbs for a snack. And we need to make sure that we adjust that for activity level. All individuals benefit from including dietary fiber as part of a healthy meal plan. The current recommendation for the general population is 25 to 30 grams per day. We know fiber can improve peristalsis in the bulk in our stool, and it also has benefits on absorbing cholesterol and reducing our triglyceride and lipid levels. Sweeteners may be included in a healthy meal plan in moderation. Dietary fat provides energy, carries fat-soluble vitamins, and provides essential fatty acids. The ADA recommends limiting saturated fat to less than 7% of total calories. Less than 200 milligrams per day of cholesterol and limited trans fat are also recommended as part of a healthy meal plan. Decreasing fat and cholesterol intake assists in reducing the risk for cardiovascular disease. The amount of daily protein in the diet for people with diabetes and normal renal function is the same as for the general population. 15 to 20% of total calories should come from proteins. High protein diets are not currently recommended for weight loss with people with diabetes. Although in the general population, high protein diets have been elicited to quicker weight loss, there are no long-term effects that are substantiated with patients that are diabetes. We have to remember that high-protein diets are a heavy burden on the kidneys, which is something we worry about with diabetics in the long term, and high-protein diets have not been found to increase insulin sensitivity or reduce that insulin resistance. Alcohol inhibits gluconeogenesis, or the breakdown of glycogen to glucose, by the liver. This can cause severe hypoglycemia in patients on insulin or oral hypoglycemic medications that increase insulin secretion. Creating a trusting environment where patients feel comfortable being honest about their use of alcohol is essential because its use can make blood glucose more difficult to manage. Moderate alcohol consumption can be safely incorporated into the meal plan if the person is monitoring their blood glucose levels and if the patient is not at risk for other alcohol-related problems. Moderate alcohol consumption is defined as 1 drink per day for women and 2 drinks per day for men. A patient can reduce the risk for alcohol-induced hypoglycemia by eating carbohydrates when drinking alcohol. On the other hand, some patients who drink sweetened drink mixes can lead to elevations in blood glucose or hyperglycemia. So in those patients, we want to make sure that they're drinking sugar-free mixes and light wines. Most often, the dietitian initially teaches the principles of nutrition management. Whenever possible, be prepared to work with dietitians as part of an interprofessional or interdisciplinary diabetes care team. In some instances, access to a dietitian is not possible for patients in certain remote areas or patients with limited insurance coverage. In these cases, we as the nurses may need to assume responsibility for teaching basic nutrition to patients with diabetes. There are several meal plans that we can discuss with patients. The first one is carbohydrate counting. Carbohydrate counting is a meal planning technique that people with diabetes use to keep track of the amount of carbohydrates they eat with each meal and per day. We need to advise patients to keep carbohydrates within a healthy range. The amount of total carbohydrates per day depends on blood glucose levels, age, weight, activity level, patient preference, and prescribed medications. A typical serving size of a carbohydrate is 15 grams. A typical adult usually starts with 45 to 60 grams of carbohydrates per meal. For some patients, insulin doses are tailored to the number of carbohydrates the patient will consume at a meal, with a set number of units per insulin given with each 15 grams of carbohydrates. A typical amount of insulin given with 15 grams of carbohydrate might be somewhere from 2 to 3 units of a fast-acting or regular-acting insulin. Teach the patient about the foods that contain carbohydrates, how to read food labels, and appropriate serving sizes. Another nutritional therapy meal planning is the exchange list. Diabetes exchange lists are another method for meal planning. Instead of counting carbs, the individual is given a meal plan with a specific number of helpings from a list of exchanges for each meal and snack. The exchanges are starches, fruits, milks, meat, vegetables, fat, and free foods. The patient chooses foods from the various exchanges based on the prescribed meal plan. This method may be easier for some patients than carbohydrate counting. It also encourages a well-balanced meal plan. Another advantage is that this approach helps the patient limit portion sizes and overall food intake, an important component of weight management. Whenever possible, include family members and caregivers in nutrition education and counseling, particularly the person who cooks for the household. However, the responsibility for maintaining a healthy eating plan still belongs to the person with diabetes. Reliance on another person to make health decisions interferes with the patient's ability to develop self-care skills, which is essential in the management of diabetes. We need to foster independence, even in patients with visual or cognitive impairment. It is also important to discuss traditional foods with the patient. Individualized food choices to take into account the patient's preferences and foods that are culturally appropriate. In an acute health care facility, the nutritional needs of the diabetic patient vary slightly from the normal meal plans. Previously, standardized calorie level meal patterns were used, but new systems are now being used, such as the consistent carbohydrate diabetes meal plans. Under this system, meal plans are created with consistent carbohydrate content. For example, breakfast contains the same amount of carbohydrates every day. My Plate was developed by the U.S. Department of Agriculture, or the USDA, to represent national nutrition guidelines for people with or without diabetes. This simple method helps the patient visualize the amount of vegetables, starch, and meat that fills a 9-inch plate. The recommendation is that each meal has 1/2 of the plate filled with non-starchy vegetables, 1/4 filled with the starch, and 1/4 filled with protein. And we round it off with an 8-ounce glass of milk and a small piece of fruit. The ADA recommends that people with diabetes engage in at least 150 minutes per week of exercise. This could be broken down into 30 minutes, 5 days a week. We need to make sure that these patients get moderate to intensity aerobic physical activity, such as walking, swimming, biking. The ADA also encourages people with type 2 diabetes to perform resistance training 3 times a week in the absence of contraindications. Exercise decreases insulin resistance and can have a direct effect on lowering blood glucose levels. It also contributes to weight loss, which can also decrease insulin resistance. The therapeutic benefits of regular physical activity may result in a decreased need for diabetic medications in order to reach target blood glucose goals in people with type 2 diabetes. Regular exercise may also help reduce triglyceride, LDL cholesterol levels, increase HDL levels, which are our good cholesterol lipoproteins, reduce blood pressure, and improve circulation. Any new exercise program for patients with diabetes needs to be started after medical clearance. This might be a physical exam, or it might be something even a little bit more extreme, like a stress test. Patients need to start slowly with gradual progression towards their desired goal. Patients who use insulin, sulfonylureas, or meglitides are at increased risk for hypoglycemia when physically active is increased, especially if the patient exercises at the time of the peak drug action or if food intake has not been sufficient to maintain adequate glucose levels. This can also occur if a normally sedentary patient with diabetes has an unusually active day. We also need to remember that the glucose-lowering effects of exercises can last up to 48 hours after the activity has stopped. So it's possible for these patients to become hypoglycemic long after the activity. It is recommended that patients who use medications that can cause hypoglycemia should schedule their exercise session about an hour after each meal, or that they have a 10 to 15 gram carbohydrate snack and check their blood glucose level before exercising. Small carbohydrate snacks can be taken every 30 minutes during exercise to prevent hypoglycemia. Patients using medications that place them at risk for hypoglycemia should always carry a fast-acting source of carbohydrates such as glucose tablets or hard candies when exercising. Although exercise is generally beneficial to blood glucose levels, strenuous activity can be perceived by the body as stress, causing a release of the counter-regulatory hormones that result in a temporary elevation of blood glucose. In a person with type 1 diabetes who has hyperglycemia and ketones, exercise can worsen these conditions. We need to teach our patients to delay activity if the blood glucose is over 250 and ketones are present in their urine. If hyperglycemia is present without ketones, it is not necessary to postpone exercise. Self-monitoring of blood glucose is a critical part of diabetes management. By providing a current blood glucose reading, the primary advantages of blood glucose monitoring is that it enables the patient to make decisions regarding food intake, activity patterns, and medication dosages. It also produces accurate records of daily glucose fluctuations, trends, and alerts the patient to acute episodes of hyperglycemia and hypoglycemia. Furthermore, it provides patients with a tool for achieving and maintaining specific glycemic goals. SMBG, or self-monitoring of blood glucose, is recommended for all patients who use insulin to manage their diabetes. Other patients with diabetes use SMBG to help achieve and maintain glycemic goals and monitor for acute fluctuations in blood glucose related to medications, food, and exercise. The frequency of monitoring depends on several factors, including the patient's glycemic goals, the type of diabetes that the patient has, the medication regimen, the patient's ability to check blood glucose independently, and the patient's willingness and ability to do so. The recommendation for patients who use multiple insulin injections or insulin pumps is to monitor their glucose 4 or more times a day. Patients using less frequent insulin injections, non-insulin therapy, or medical nutrition management will monitor as often as needed to achieve their glycemic goals. Because errors in monitoring techniques can cause errors in management strategies, comprehensive patient teaching is essential. Initial instructions should be followed up with regular reassessment. We need to review the instructions that accompany each product for how to use that particular glucose monitor. Teach patients to use and interpret calibration and control solutions. Control solutions should be used when the blood glucose meter is first used, when a new bottle of strips are opened, or if there is a reason to believe that the readings are not correct. People with type 1 diabetes often test their blood glucose before meals. This is known as preprandial. We want these patients to be between 80 and 130. And this is because many patients use insulin pumps or daily injections and base the insulin dose on the carbohydrates in a meal or make adjustments if the pre-meal value is above or below target. Checking blood glucose 2 hours after the first bite of meal helps a patient determine if the bolus insulin dose was adequate for meal. This is typically known as the postprandial blood glucose. We want this number to be less than 180. We need to teach patients to monitor blood glucose whenever hypoglycemia is suspected so that immediate action can be taken. During times of illnesses, we need to check our blood glucose levels at least every 4 hours to determine the effects of the illness on glucose levels. Typically, illness and stress can raise our blood glucose levels. We need to teach the patient to monitor blood glucose levels before and after exercise to determine the effects of exercise on our glucose levels. This is especially important in a patient with type 1 diabetes. A patient who is visually impaired, cognitively impaired, or limited in manual dexterity needs careful evaluation of the degree to which SMBG can be performed independently. Nurses preparing patients for discharge from the hospital and those working in home health and outpatient settings need to identify caregivers who can assume this responsibility. Adaptive devices are available to help patients with certain limitations. These include talking meters and other equipment for the visually impaired. Some systems allow the user to collect blood from alternate sites, such as the forearm or palm. Alternate site use is not recommended when blood glucose readings change rapidly during pregnancy or when the symptoms of low blood glucose levels are present. The data from some glucose monitors can be uploaded to a computer and reviewed by physicians, allowing for more frequent and efficient adjustment of the plan of care if needed. Continuous glucose monitoring systems provide another route for monitoring glucose. Using a sensor inserted subcutaneously under the skin, the system displays glucose values continuously, updating values every 1 to 5 minutes. Continuous glucose monitoring assesses interstitial glucose, which lags behind blood or capillary glucose by about 20 minutes. The patient inserts the sensor by using an automatic insertion device. Data are sent from the sensor to a transmitter, which displays the glucose value on either an insulin pump or a pager-like receiver. The continuous glucose monitor can be used with or without an insulin pump. CGMs assist the patient and HCP to identify trends and patterns in glucose levels and are useful for the management of insulin therapy or when continuous blood glucose readings are clinically important. The patient is alerted to the episodes of hypoglycemia and hyperglycemia, thus allowing corrective action to be quickly taken. Both systems will require fingerstick measurements and the use of blood glucose monitor to calibrate the sensor and make treatment decisions. Because culture can have a strong influence on dietary preferences and meal preparation practices, culturally competent care has relevance for the patient with diabetes. For example, certain ethnic and cultural groups such as Hispanics, Native Americans, African Americans, and Asian Pacific Islanders have a high incidence of diabetes. The increased prevalence can be attributed to genetic predisposition, environmental factors, and dietary choices. We need to make sure that we explore the influences of culture on food choices and meal planning with the patient as part of the health history. When giving diet instructions, consider the patient's cultural food preferences. Nutrition resources specifically designed for members of different cultural groups are available from the